Okay.
Okay.
All right.
Discussion 10. Yeah, we're on 10. Okay. Let's see.
So, talking about Seema's lecture, what were our biggest takeaways, and was there anything about DID and trauma that surprised you?
Mhm. I wrote down quite a bit. The one that like really jumped out to me was that it takes 12 years for it to be diagnosed, or that's like the average amount of time. Which I think is, yeah, very wild to me. Um, and oh, one that I thought was really interesting is that some of the alters can be the perpetrators that have caused like the trauma to the person, which I think is really wild. Yeah, I'd never would have thought about that as much. Um, and then how much it's not diagnosed, how it's like seen as rare, even just because of that one like criteria that they mentioned.
Of
Yeah.
client, like it not causing clinically significant
Yeah,
impact.
distressed or yeah, and I was like, oh, I think like the overall message I got was other than it being like very like misinformed and stigmatized is that like how it could be seen like DID shows up very differently for different clients. So it's just like the DSM in general. I'm always like, well, symptoms show up differently. Why is it so rigid? Um, Especially if someone has every other criteria. But
Yeah.
yeah, what are your thoughts?
Yeah, I totally relate to that. And I do think it's frustrating that someone couldn't necessarily be like properly diagnosed with DID if it wasn't causing some severe distress or impairment in their life.
Mhm.
But I also think that's very subjective. Like, and a clinician, I think, could make that call with in collaboration with the client. Like after building trust, there may be enough information about these, the impact on a person's life of having these symptoms that then that it could be categorized as like, that part's kind of up to us. Like, is it significant?
Hmm.
Um, yeah, and also I was also very surprised to learn how common it is. I think I don't remember if it was in the reading or if it was in Seema's lecture where this I think it was in her lecture where she said that it was actually like more common than bulimia in women. Was
Yeah.
that sure?
Hmm.
That really surprised me.
Hmm.
And I was also really fascinated to learn that people who suffer from or who have DID can like speak different languages and how their body will manifest different vital signs when
Hmm.
in a different alter. And it just totally fascinates me, the body, mind, spirit interconnection. Um, yeah, that really kind of blew my mind open. It's like, whoa, speak different languages.
Yeah.
Brain is incredible, and the body.
That's what I got from it the most, I think, was like, oh, we know so little about the brain, and this like disorder is a really good representation of that. It's just like how I think I didn't know, I mean, I knew about DID, but I didn't know like as in depth of it and heard all the like kind of stereotypes of it over the years, or it being called like multiple personality disorder. But obviously, being in school, I've learned more about it. But I have to keep remembering that the alters are like completely, yeah, completely different identities. Like they are a whole person inside of another person. And I think that's where, like, it's so hard for my brain to wrap my head around that because it's just like so complex. Hmm.
Yeah, and that also had me just really reflecting on the intelligence that we have, the innately, like our capacity to do that. like that our brain has the capacity to have to fuel multiple identity experiences that can have all of these different things that line up with that, different allergies, different
Hmm.
mannerisms. And it's not like some game where that folks are playing on purpose, where they're like, let me now present as this. It's like there's a whole organization of personality and experience that happens. And I found that really fascinating.
Yeah, it also just shows how like the brain tries to cope with trauma. And it
Yeah.
just being like a result of trauma is like, one of the results of it anyways is what is also like very wild for me to try to understand.
Yeah, and I was also really thinking about how, again, back to the intelligence, and like I think we'll talk about this more in one of the further down questions about the adaptive like how this could be an adaptive strategy. And I mean it is a way that really little people, young people adapt to really unnatural circumstances. And it's kind of incredible actually that we have that adaptive capacity to compartmentalize. And yeah,
Mhm.
some of my main takeaways.
Yeah, there's so much to it, I feel like.
So much.
I guess we can move on to the reading.
Yeah.
It's, okay.
Based on the NICABM reading, what are the primary indicators that help differentiate dissociation from DID?
Mhm.
And how might these distinctions influence treatment planning?
Mhm. Um, well, the main thing I know is with DID, they need the five types of dissociation for it to be DID.
Mhm.
So depersonalization, derealization, identity alteration, identity confusion. Whereas dissociation could be just like one of these.
Mhm.
Um, though I think identity alteration isn't really like the main component of just dissociation. I mean, I get dissociation. I've had like derealization through like trauma, but not DID. I don't know how to like describe that, I guess. But yeah.
Mhm. Yeah, and the presence of with DID, there's a presence of two or more distinct identity states. And
Yes.
usually, I think I don't remember what Seema said, but I think it was something like yeah, it was in the teens was what Seema said in her lecture. That's the mean or medium, I don't know, most
Mm-hmm.
generally like in the teens, how many different alters that one person may have,
Hmm.
which is different from dissociation, where they just may um, come into a different, dissociation from self.
Hmm.
That's maybe not necessarily into a different alter
Hmm.
or multiple alters.
Yeah, that's a good way to put it. It's kind of like a removal from the self, but there's not really like a replacement like an alter.
Hmm. Also from the Nick Nick Habam reading, they talk about how with dissociative identity disorder, there's like often a lot, like huge chunks of time that go missing for folks, and um, they have no idea like where that time went. They don't have awareness of what happened during that time, and it happens, it seems, pretty regularly.
Hmm. Yeah, the dissociative amnesia, right?
Uh-huh.
Another one, yeah, I guess that was part of the article, but also in general, it was like a fact of it where DID sometimes could be misdiagnosed as schizophrenia because of voices,
Yeah.
but DID has child voices, whereas schizophrenia doesn't usually, which I think is really interesting. But it makes sense because of how it's related to CPTSD.
Hmm. Yeah, I was gonna say the same thing that
Hmm.
with DID, the voices, that's not necessarily a something that happens for folks that if they're dissociating
Hmm.
with DID, that's pretty common that they'll be different. I mean, it's necessary. It's a necessary,
Hmm.
really part of the experience, having those different identities and different voices that are happening.
Hmm.
Um, and the second part of the question, how might these distinctions influence treatment planning? So
Let's see.
if we're treating DID, then it's going to require, a longer term structured
Mhm.
approach. The readings and the video talked about the phase oriented approach to treating DID.
Hmm.
Um, Whereas with general dissociation, the approach is more around like psychoeducation and grounding, which are all things that um, can be included in DID care, but there's more of like it seems more of a phased approach that's necessary with DID.
Yeah, I think that's a good way to put it is like the kind of long-term part of it. I think with DID, I was reading that part of the like steps to it is trying to teach the client about where their hyperarousal like symptoms are and like to kind of try to notice where they are. And then that's where you regulate. Whereas like yeah, they have to like completely start over on like viewing their bodies and like how it connects to their brain, which is how like dissociation is. But like you're saying, that's more about like the grounding into your body. The symptoms are definitely like not on the same severity as DID.
Yeah, and also with DID, depending on the client, the treatment goals may be to get these different alters to have some kinds of capacity for communication with one another, or perhaps clients may want to work towards integration, although that they
Mhm.
talked about that in both of the reading and the lecture that that's sometimes not the goal for the client.
Mhm.
Whereas with dissociation, that's not happening for them, the alters. So that's not part of the treatment planning or the treatment goals.
Mhm.
Mhm.
Yeah, I guess it's more individual based. I mean, I guess, yeah, not having the alters is like kind of a multiple like identities and people involved, whereas like, yeah, dissociation is just the one person. So, yeah, that's a good thing to remember too.
And in treatment planning with someone with DID, it's like you're essentially working with multiple clients.
Hmm.
So there'll be a different treatment plan really for each of the alters and what each of the alters needs,
Hmm.
wants, is capable of, what their age is, like what their whole world is, right? So that's very unique to working with someone with DID.
Yeah, definitely. I could see where that could be a very, very long process because you would have to teach each alter how to regulate their emotions in a different way.
Uh-huh. I thought it was really important that Seema noted about getting like consent from the alters to share information that one alter shared like with another alter or with the host. Um, yeah, that really like moved me. I like could feel the importance in the framing, the trauma informed care of like respecting each alter as an individual and getting their consent to be able to break confidentiality essentially
Yeah.
with
Hmm.
them to share with the host or to share with another alter.
Hmm.
Like I wouldn't have maybe thought of that on my own.
Yeah, me
I
either. Yeah. Um,
can see how kind that is and respectful and important.
yeah, definitely. Yeah, that's so much, so many different like factors to it that if I ever have like a client that has DID, I'll have to be like, okay, to definitely have like a place of curiosity with like all of the alters and see which ones I could actually talk to or not talk to and everything. How they come up in session too. I wonder how that is, but
Mhm.
yeah.
Okay, should we move on to the next question for time's sake?
Hmm.
Okay, I could keep talking about even just the first one. It's so interesting. Okay, somatic symptom disorders often involve significant distress related to bodily experiences. How might dissociation and somatic symptoms be interconnected? And what challenges might a clinician face in assessing severity? Those are two very different questions.
Hmm.
Do you want to start with the first part of the
Let's
question?
see.
How might dissociation and somatic symptoms be interconnected?
Hmm. Um, Wait, what do my notes say? How might they be? Well, I think it's kind of like dissociation would be a defense mechanism from the somatic, like symptoms being really severe. So I would assume that the body would want to go into dissociation to um, kind of try to release the severity of the somatic symptoms, if that makes sense.
Mhm.
Um, yeah. What are your thoughts? I don't know if that like.
Yeah, that lands.
Mm-hmm.
Um, well, I mean, somatic symptoms like chronic pain and fatigue and like intestinal gut issues, um, are really relevant to folks that have trauma. And so I would, and like, again, there's this interesting aspect of like each of the alters might have different somatic symptoms that they express based on how they're relating to the trauma or who they are and in the story if they're the embodied the internalized perpetrator or what phase of themselves they are in that alter.
Mm-hmm.
So yeah, that's I think the somatic symptoms are related to the trauma,
Mm-hmm.
and so they're both ways, the dissociation and the somatic symptoms are ways that like the organism is attempting to process and deal with the
Mm-hmm.
trauma.
Yeah, it's like a manifestation, like trying to externalize what's happening inside.
Mm.
Hmm. Yeah, definitely.
And then the second part of that question is what challenges might a clinician face in assessing severity?
I think for what I was like trying to figure out was maybe how there might be such a disconnect between like symptoms versus dissociation, and how it would be difficult to assess the severity if there is that disconnection. Because it would be like, okay, your somatic ones are like on this scale versus like this is your dissociation, or like how dissociative they are could really affect how they present somatically.
Hmm.
So I think it's a lot of like trying to help the client like relearn where they are in their body versus like their mind.
Hmm. Yeah, I also think that again, because each alter may have different symptomology in terms of how they're dealing with the trauma and what's going on in their body experience with each alter. And some alters, like a clinician might never meet or never express in the room. And because the alters don't necessarily communicate with one another or with the host, and the host then has amnesia when the alters there, like the host may have not know how many there are and what the experiences of each of them if they forget each time, if they have amnesia each time. But and I feel curiosity about that because also in Seema's lecture, she said that they usually know, and I think in this reading also they talked about how someone who has DID usually knows it. They maybe don't call it that. They might not know that they have DID, but they know that they're they have these different identities that are expressing.
Mhm.
But how do they know that if they have amnesia about what happens when one of the alters is manifesting? I just feel I don't quite understand how
Mm.
that works because if they don't remember it, not
That's
sure. That's a question that I have.
that's a good point. That was a note I forgot to mention was how like a lot of the alters are the missing memories of the dissociative amnesia, like they were like born out of those. So that's a good point. Like how would the host be able to kind of backtrack if they're unable to like find where the amnesia is? Like if it's connected to another alter, I'm not really sure. Yeah.
Yeah, and so maybe it's through the relationships, their relationships with people in their lives and with the
Hmm.
clinician themselves that they come to know their their alters
Hmm.
parts. Um, yeah, that makes it hard to assess
Hmm.
what's really, how what's really going on. And yeah, and just to assess in general, it's like, how do I know if I'm in the room with someone, how do I know how many altars somebody's dealing with and what memories are buried in one altar that, I mean, that's the other thing. I can do an assessment with the host,
Hmm.
with the person, with the individual in their host state,
Hmm.
and they may be missing like huge gaps of information about what they've even been through in their life and what their trauma is. And um, so I could ask them all kinds of questions and we could be in dialogue about parts of their lives and parts of their story, and they don't remember. So there's a way that it's like kind of a chance thing. Like if one of the alters is going to show up in the room, then I have the capacity to maybe then I can assess with that alter and I'll get a whole bunch more information. And then I guess like with consent from that alter, I could share that information with the host.
Hmm.
That can help them to build like a broader picture of themselves and their story.
Yeah, which I guess that goes back to the like how long it takes to diagnose DID is because of how many different factors there are in there. Yeah, very complicated.
It is complicated and fascinating.
Hmm.
So the next question is share a clinical or theoretical perspective. Do you think dissociation is always pathological or can it serve an adaptive function and support our responses?
Well, yeah, it's similar to the last question where I said that it's like a defense mechanism. It's like a trauma response. So it's for survival. And
Mhm.
in the article, there's the mention of like the client being in the childlike state in DID and how that came about because they're looking for caregiving from the therapist, which is like an adaptive function for that traumatized like child parts that they have. So, yeah, I feel like dissociation kind of shows that the body doesn't feel safe. So the adaptive function is having these different alters that are able to try to find like comfort, yeah, and caregiving through their different identities.
Mhm. Yeah, such a great perspective. Thank you for sharing that.
Mhm.
I totally agree, and I just still struggle with sort of the idea of like pathology in
Mhm.
general. Like one of the things that really stuck out to me also from Seema's lecture was when she talked about the like percentage of she said trauma is the most common factor in all disorders in the DSM.
Mhm.
And like when I zoom out and I like think about pathology, it's like those are all the cuts and the bruises and
Mhm.
the scars and the bleeding out and like all these ways that the body like is showing where it's been where the being is showing where and how it's been harmed and trying to like adapt to it and like the body sends antibodies and it sends like you know, blood cells to the places where it's been harmed. And it's like, to me, the pathology and the symptomology in a lot of ways, like the way I'm conceptualizing it is like it's all adaptive, really. It's all adaptive. It's all maybe, initially adaptive and it becomes maladaptive because, some of these symptoms, some of these ways of being in the world are no longer serve somebody to
Hmm.
live their best life or to live a life of joy, but they all come from the personality or the person or the heart or the soul of a human, like trying to heal itself from something that's happened to them. Like I think of like the trauma is the most common factor in all of the disorders. The disorders are just like names for all the way, like all the things, all the ways that people are trying to
Hmm.
cope with having been stabbed in the heart.
Hmm.
And I think back to, I don't remember which class it was, but it was like, I think it was maybe early on in this class that was talking about how, like, or maybe it was in my sexuality class, I'm not sure, but how, like, so many of the ways of being that are the perpetrator, like, are not in, there's no diagnosis for that
Hmm.
in the DSM.
Oh, yes, there is an article I read of that also that I remember. Hmm.
And to me, it's like, that's the cause of all this whole book,
Hmm.
huge book. And like, that's pathology.
Hmm.
But also, probably all those perpetrators, what do they probably have?
Exactly.
Trauma.
Yeah, exactly.
Yeah.
Yeah.
So that's my 2 cents on that topic.
Yeah, I mean, I definitely feel exactly the same. Whenever I read the DSM, even if I understand more of the necessity of it, and as
Mhm,
someone who has like multiple diagnoses, I could see like the benefits or some
mhm,
that I'm like, well, what categorizes someone to have this disorder? Even though it's just super off topic to this, but I think about grief disorder and how, like, why is that a disorder for someone who's undergoing like extreme amounts of grief? I just don't understand why you just put like I guess, a blanket statement on someone. Whereas,
mhm.
like you're saying, it's just like that's how they're adapting. They're trying to go through grief. But yeah, it's
Yeah, it's
just
like,
you know.
and go ahead.
Hmm. Yeah, it's we don't need to pathologize, I don't know, what people are trying to, yeah, how to adapt from their trauma. But yeah.
I see it more as like, how can how can we as clinicians like
Hmm.
help people to find adaptive strategies that are more enjoyable.
Yeah. Hmm.
Like we're
Hmm.
still gonna have to be adaptive to whatever happened to us, whatever's happening. And like, how can we, I think about for myself, like, how do I find strategies for myself that are more adaptive, less self-harmful, less
Yeah.
harmful to others,
Hmm.
and ultimately like liberate more life force energy for me, allow
Hmm.
me to feel more alive and in love with life and enjoy in life. And I think that's what it's all about.
Hmm. Yeah, I think that's a good way to end this conversation.
Thank you so much, Luz.
Thank you.
Yeah.